In this video, we will learn about the drugs which are known as diuretics. Technically, a diuretic is an agent that increases the urine volume. So there are many abnormalities that are associated with fluid volume and electrolyte composition, and they are responsible for many clinical disorders. So diuretics are the drugs that block specific transport mechanisms of the in the renal tubules, and they are very valuable clinical tool in the treatment of these disorders. The first diuretics, they were introduced in 1937, and the class of drugs were carbonic anhydrase inhibitors. So the outline of this whole video is that we will start with the structure of nephron. In order to understand the mechanisms by which these drugs act, we must have a sound knowledge of the structure of nephron. So we will start with the structure of nephron, which is number one. Then we'll discuss what are diuretics. I have given a brief introduction on diuretics, that these are the drugs that increases the urine volume in a body. Then we'll discuss the mechanism and site of action of different diuretics, and then there will be clinical uses and toxicity of diuretics. So we will cover all these topics in this video. So let's start with the structure of nephron. Okay, so here we can see that we have taken a small segment of kidney here, and this is basically magnified. So this is a nephron, and we can see that the nephron, it starts from here. Like, these are the blood vessels, this and this, and these are the arteries which are entering here. So the nephron basically starts from here. So here we can see that there is a cluster of capillaries, and which is surrounded by a capsule. So this capsule is known as Bowman's capsule. So inside the Bowman's capsule, there is a cluster or collection of capillaries which is known as glomerulus. So this is the glomerulus and Bowman capsule. This is the first unit of the nephron. So we can see that there are certain blood vessels that are entering the nephron, the glomerulus, and there are certain arteries which are leaving or which are exiting the glomerulus. So the arterioles which are entering the glomerulus are known as afferent arterioles, and which are exiting are known as efferent arterioles. Now, after the glomerulus, we can see that this is the structure of glomerulus. There is this tubule system starts. Now, this tubular system, it goes the whole length of the nephron, and it ends in the collecting tubule. So we can see that it starts from the glomerulus, and after the glomerulus, we can see that here we have this part in the blue, and this is known as distal convoluted tubule. Proximal convoluted tubule. After the proximal convoluted tubule, we have a U-shaped structure. We can see this structure. This U-shaped structure is known as the loop of Henle, and we can see that certain segments of this loop of Henle are thick, and this part here is thin. So this part here, it is known as the descending loop of Henle because it is going downwards, and the part that is going upwards is known as the ascending loop of Henle. So after ascending loop of Henle, we have another convoluted tubule which is known as distal convoluted tubule. So we have two convoluted tubules. This one is proximal, and this one is the distal proximal convoluted tubule. From here we can see that there is a long tubule, and this is known as collecting tubule. So this is the whole structure of the nephron. The red arteries, or the structure that is going inside the efferent arteriole, and that is providing the arteriole with the oxygenated blood is known as it's coming from the renal artery. And we have a renal vein which moves alongside the renal arterioles. So this is the structure of the nephron, and we must understand the segments of the nephron, because in order to understand the mechanism by which the diuretics act, we must have a very sound knowledge of the structure of the nephron. Okay, so here we can see that there is a more detailed structure of nephron, and it is a more simplified version. We can see that the nephron, it starts with the glomerulus, then we have the proximal convoluted tubule, then we have this U-shaped structure which is called as loop of Henle. After the loop of Henle, we have another tubule which is known as distal convoluted tubule, and after the distal convoluted tubule we have a long collecting tubule, long duct, or which is known as collecting tubule. So these are basically the segments of the nephron, and we will study at each segment of the nephron differently or separately, and then we'll discuss because on each segment there is a drug that act separately on each segment. So we will discuss all the segments separately and the drugs that are acting on these segments. So moving on, and the first structure of the nephron was glomerulus, and the function of the glomerulus is to make glomerular filtrate, and there is no reuptake in that area, and all of the blood is filtered, and the glomerular filtrate is then transferred into the proximal tubule. So the first segment that we are going to be discussing is the proximal tubule. So in the proximal tubule, we can see in this diagram that there are three main sections. So these are the cells of the proximal tubule. These cells are interconnected with each other. Here we can see there is lumen in which the urine is present, and here is the interstitium. So these are the three main divisions of the proximal tubule, and along with the tubule, the other sections that are interconnected with the proximal tubule. Now, what actually happens is that in the proximal tubule, there are many ions and many salts which are transported, which include sodium bicarbonate, sodium chloride, glucose, amino acids, and other organic solutes. So all these things, they are reabsorbed in the proximal tubule. So let's revise that: sodium bicarbonate, sodium chloride, glucose, amino acids, and different kind of organic acids, they all are reabsorbed in the proximal tubule. So here we have a transporter which is known as NHE3. So NHE3 is basically a sodium and sodium and hydrogen exchange transporter, which causes the influx of the sodium and the outflux of the proton. So what actually happens is that when the proton comes out of the cell, it combines with the bicarbonate that is present in the lumen of the urine and forms the carbonic acid. Now this carbonic acid, it will rapidly disintegrate into water and carbon dioxide. This carbon dioxide and water will go inside the cell, and carbonic acid is again formed, which is then converted into bicarbonate and proton. So as a result, what we can see is that proton, it gets out, it combines with the bicarbonate, and this bicarbonate, this carbonic acid, which is converted into the bicarbonate, eventually goes inside the cell. So we are reabsorbing sodium and we are reabsorbing the bicarbonate. This is an enzyme which is known as Ca or carbonic anhydrase. This enzyme, it plays a very important role because it converts the carbon dioxide plus water into carbonic acid, and this enzyme also breaks down the carbonic acid into the bicarbonate and proton. So the net effect is that bicarbonate is being reabsorbed from the lumen, from the urine, and the sodium is also reabsorbed. And likewise, the chloride is also going inside the cell, and there is reabsorption of glucose and amino acids and all other organic acids. And now everything is not displayed in this image because we are only concerned with the diuretics here, and the enzymes that are responsible for the drugs that are responsible for the enzyme inhibition, they will be discussed here. First class of the drugs are known as carbonic anhydrase inhibitors, and these include carbonic anhydrase inhibitors, and these include acetazolamide, number one, and it is the prototypical of all the diuretics. And then there is dichlorphenamide, and methazolamide. We also have another carbonic anhydrase inhibitor, dorzolamide, and all these are used for the treatment of glaucoma, whereas acetazolamide is used in the treatment of increased intraocular pressure and increased intracranial pressure, also as well as a diuretic. So the carbonic anhydrase inhibitors, these are responsible for as the name indicates, they inhibit the enzyme which is known as carbonic anhydrase. So this enzyme, it is responsible for the conversion of carbon dioxide plus water into carbonic acid, and it further converts, this carbonic acid is further degraded again into bicarbonate plus hydrogen ion. So we inhibit this enzyme. This enzyme is inhibited, so all this process is also inhibited. As a result, this bicarbonate, it will be lost in the urine. It does not get reabsorbed into the urine, and it is lost in the urine. So this is how the carbonic anhydrase inhibitors work. We'll go back to the previous diagram. We can see that here this carbonic acid, which is formed by the combination of bicarbonate plus proton, this is converted into carbon dioxide and water, and it goes inside the cell. Now we have inhibited this enzyme, this carbonic acid enzyme, we have inhibited this. So there will be no conversion of carbonic acid into water and carbon dioxide, and this will be lost in the urine. So this is how we are getting rid of the excess bicarbonate. Along with that, there will be loss of water as well, and this is how it acts as a diuretic. However, there are some drawbacks that are associated with the carbonic anhydrase inhibitors. Number one is that when there is an increased loss of bicarbonate in the proximal tubule, as a result, there is an increased uptake of sodium, or there's an increased uptake of bicarb in the rest of the kidney, in the rest of the tubules of the nephron. So as a result, that these carbonic anhydrase inhibitors, they're not good diuretics for long-term use, because the diuretic efficacy will be reduced with prolonged use. However, we can still use these carbonic anhydrase inhibitors in other uses as well. So we'll discuss them as we move further. So first we'll discuss the pharmacokinetics of the carbonic anhydrase inhibitors. They are well absorbed after oral administration. Hydrochlorothiazide is available in the oral tablet form and it is very well absorbed from the oral route. The onset of action is 30 minutes, that we will see the effect or the alkalization of the urine after 30 minutes, and the peak effect will come after 2 hours, which means that the effect will start or will initiate at 30 minutes, but the peak of the effect or peak of the diuretic activity will be observed after 2 hours of the drug administration. The excretion of the drug is via the S2 segment of the proximal convoluted tubule. So here the drug is also excreted. So this is how it gets excreted out of the body. We have already discussed a bit about the pharmacodynamics or the mechanism by which it causes the bicarbonate reabsorption. So carbonic anhydrase inhibitors, they depress bicarbonate reabsorption in the proximal convoluted tubule. Also, they are responsible for the depression of the bicarbonate in the aqueous humor of the eye. As a result, there is a decreased production of the aqueous humor. Now, when there is a decreased production of aqueous humor, the intraocular pressure is decreased. So when the intraocular pressure is decreased, it is used in the treatment of glaucoma. So this is how it is used in the treatment of glaucoma. Now, this carbonic anhydrase enzyme, it is very important, and it is also present in the CSF, and it is also associated with the production of CSF. So when we inhibit the carbonic anhydrase enzyme, there is a decreased production of CSF, and likewise it is used in the treatment of increased intracranial pressures. It is a very valuable drug in all these conditions. This was about the pharmacodynamics of this drug. As far as the indications are discussed, number one or the most important indication of carbonic anhydrase inhibitors is glaucoma. And we have already discussed the mechanism by which it acts in the glaucoma. Second is urinary alkalinization. Now, how does this happen? We have already discussed that it prevents the reabsorption of bicarbonate. Now, bicarbonate, it is a base. So when this base, or it is also known as an alkali, base and alkali, they are interchangeable words for the same thing. So when this bicarbonate, it is released or it does not get reabsorbed from the lumen, it alkalinizes the urine, and that is how we can get rid of different kind of salts from the body. So uric acid or cysteine, they are relatively insoluble and they may form stones in the acidic urine. So in cystinuria, which is a disorder of cysteine reabsorption, the solubility of cysteine can be enhanced by increasing the urinary pH from 7 to 7.5. So when the urine is alkalinized and the pH of the urine is high, as a result, there will be decreased, or there will be basically an increased excretion of the cysteine from the urine. So the effect of the carbonic anhydrase inhibitors are also utilized in this way. in the alkalization of the urine. So the third use is the metabolic alkalosis. When the levels of the alkali in the body are high, we use carbonic anhydrase inhibitors to decrease the metabolic alkalosis. So it is usually treated by the correction of abnormalities in the total body potassium, intravascular volume, and mineralocorticoid levels. However, when the alkalosis is due to excessive use of diuretics in the patients with heart failure, so acetazolamide can be useful in correcting the alkalosis as well as producing a small additional diuresis for the correction of volume overload. It can be used for to rapidly correct the metabolic alkalosis that may appear following the correction of respiratory acidosis. Fourth important use of carbonic anhydrase inhibitor is metabolic. Acute motion sickness. The mechanism of reducing the motion sickness is because it reduces the edema, it reduces the cerebrospinal fluid concentrations, and also decreases the pH of the CSF and the brain. Acetazolamide, it can increase the ventilation, and when the ventilation is increased, it diminishes the symptoms of mountain sickness. So the mild metabolic central and cerebrospinal fluid acidosis is also useful in the treatment of sleep apnea. Now there are also some other uses of the carbonic anhydrase inhibitors. There are some conditions in which in which there is a CSF leak, for example, in CSF rhinorrhea, and the CSF leak, it could be due to a trauma or any tumor, or sometimes it's also idiopathic. So by reducing the rate of CSF formation and intracranial pressure, the carbonic anhydrase inhibitors, they can significantly slow the rate of CSF leakage. Now the toxicity of the carbonic anhydrase inhibitors is basically the direct extension of the therapeutic effect. For example, we use it to treat metabolic alkalosis. So it can also cause metabolic acidosis because it will excrete the bicarbonate to an extent that the result will be metabolic acidosis. There is no alkali in the body, and there will be a certain metabolic acidosis. It can also form renal stones. Now, these renal stones are due to phosphaturia or hypercalciuria occur during when the bicarbonate is being excreted from the body. Along with that, the calcium and phosphate is also lost in the urine. So these both ions, phosphate and calcium, they can also accumulate in the urinary tract and may form stones. So they are responsible for the treatment of renal stones as well. The carbonic anhydrase inhibitors, as it is common with all other diuretics, they're also involved in the renal potassium wasting, and it can occur because of increased sodium presented to the collecting tubule with bicarbonate is partially reabsorbed. So it increases the lumen negative electrical potential in that segment and enhances basically the potassium secretion. So there are some also other toxicities which includes drowsiness or paresthesias that are common because it crosses the blood-brain barrier and it decreases the pH of the brain. So drowsiness and paresthesias, these are common with the use of carbonic anhydrase inhibitors, but they are associated with large doses of acetazolamide. So they may also accumulate in patients who have renal failure, which can lead to nervous system toxicity. There have been some hypersensitivity reactions that are reported with the use of carbonic anhydrase inhibitors. Now, there are some contraindications which are associated with the use of carbonic anhydrase inhibitors. So as we have already established, or we have already studied, that the use of carbonic anhydrase inhibitors, it alkalinizes the urine. So when the urine is alkalinized, there is a decreased now there is a decreased urinary excretion of ammonia. So this ammonium ion, it does not get excreted in the alkalinized or the basic urine, so it gets accumulated in the body in the form of ammonia. And in the patients who have a condition called as hepatic encephalopathy is basically a condition in the liver failure in which there is an increased accumulation of ammonia in the body, which results in the loss of consciousness in the patient, and it can also induce coma in the patients with liver failure. So in the patients who already have an hepatic encephalopathy, which is associated with the chronic liver disease, the increased accumulation of ammonia can further exacerbate the situation, and the patients may deteriorate with the use. So we have to contraindicate the use of carbonic anhydrase in patients with with liver failure. Now we'll move on. So this was all about the carbonic anhydrase inhibitors. Now we will move towards the thin ascending loop of Henle. So we have already discussed that when we come out of the glomerulus, there is proximal tubule, and then there is this U-shaped structure which is known as loop of Henle. So in the loop of Henle, there is a segment which is thin, and then there is a thick segment of the loop of Henle. So now we'll discuss the thin ascending loop of Henle. So in the thin ascending loop of Henle, there is a passive reabsorption of water, and only water is being reabsorbed in this section. There are certain drugs that act in the thin ascending loop of Henle, which includes the osmotic diuretics. These osmotic diuretics include mannitol. We'll discuss in detail in the collecting duct segment, because mannitol, it also exerts its action in the collecting duct. So in the thin ascending loop of Henle, because there's only reabsorption of water, and there are aquaporins which are responsible for the reabsorption of water. There are no drugs that act directly on these aquaporins, and which have any major action on these apart from the osmotic diuretics, which basically exhibits an osmotic pressure and causes the inflow of the water. So after the thin ascending loop of Henle, we have thick ascending loop of Henle. So in the thick ascending loop of Henle, we have reabsorption of many ions. It includes the reabsorption of potassium. It includes the reabsorption of calcium, sodium. We have magnesium. We have chloride. So all these ions, they are reabsorbed in the thick ascending loop of Henle, and the drugs that act on the thick ascending loop of Henle are very important drugs. These are also called as loop diuretics, and they play a very major role as they manipulate the concentrations of these ions as well as the water. So the channel here which works is known as NKCC2. NKCC2 is basically sodium, potassium, chloride and calcium channel with chloride channel. And this channel, what it does is that it causes the inflow of sodium, potassium and chloride ion. So there are two chloride ions that are associated with the inflow of one sodium and one potassium. This is why it is known as NKCC2. because two chloride ions are going inside along with the sodium and potassium. So the electrophysiology remains constant. So there is also a gradient that causes the outflow of potassium, and this outflow of potassium causes the inflow of magnesium and calcium. So the reabsorption of all these important ions is happening in the thick ascending loop of Henle. So any drug which manipulate or which block this NKCC2 will have a great impact on the concentrations of all these ions. So we really need to understand the mechanisms that are happening in the thick ascending loop of Henle. Now what happens is that when the sodium goes inside, it goes into the interstitium of the blood, and for one sodium, one potassium is transferred into the in the tubular cell. Now this potassium, it goes out and it causes the inflow of the magnesium and calcium. So we have inside, we have sodium, we have magnesium, we have calcium, and all these ions, they are being reabsorbed in the thick ascending loop of Henle. So now we have discussed the ions. Let's discuss some things about the water reabsorption. Water is extracted from the descending loop of Henle by the osmotic forces. There are no channels involved. The osmotic forces are basically playing a role in the extraction of the water from the lumen, from the urine into the tubular cells, and then ultimately into the interstitium of the blood. So now we'll discuss the drugs that are used or that basically blocks this NKCC2 channel and plays a very important role as a diuretic. So these are known as loop diuretics. The loop diuretics, they selectively inhibit the reabsorption of sodium chloride in the thick ascending loop of Henle. Because of the large sodium chloride absorptive capacity of this segment and the fact that diuretic action of these drugs is not limited by the development of acidosis as in the case with carbonic anhydrase inhibitors, these are the most efficacious agents that are currently available. So the prototype of these drugs are furosemide. We have ethacrenic acid, bumetanide, and we have torsemide. A little bit about the chemistry. All these drugs are sulfonamide loop diuretics. Ethacrenic, apart from ethacrenic acid, which is not a sulfonamide diuretic, it is a diuretic of phenoxyacetic acid, which have a ketone and a methylene group. It is not a sulfonamide. So among all these loop diuretics, ethacrenic acid is the only one which is not sulfonamide. Apart from this drug, all the furosemide, bumetanide, and torsemide, they're all sulfonamide. So if the patient is sulfa allergic, we cannot give them these drugs. Moving on towards the pharmacokinetics of these drugs. So the loop diuretics, they are rapidly absorbed. They are they have a very rapid oral absorption. The mechanism or the onset of action or the peak effect of these, it ranges from 1 hour to 3 hours. For torsemide, the peak effect, it occurs in 1 hour, and for furosemide, the peak effect of the drug, it occurs in approximately 2 to 3 hours. So the duration of action of torsemide is 4 to 6 hours, whereas the duration of action of furosemide is slightly shorter, and it lasts for around 2 to 3 hours. All these drugs, they are secreted into the proximal tubule, and from there they are excreted out of the body. So the excretion of these drugs is through the proximal convoluted tubule. From where they go out of the body and excrete out of the body, basically. In the pharmacodynamics, we have already discussed that they block the NKCC2 channels, and this is how they prevent the reabsorption of sodium and chloride. Also, there's decreased excretion of potassium and magnesium and calcium and all the ions which we have already discussed. It also diminishes the Lehman positive potential, and it also the expression of COX basically reduces the efficacy of loop diuretics. The indications of loop diuretics are vast. They are used in any condition in which there is fluid accumulation in the body, and the most important of these is congestive heart failure. They are used in the all kind of edematous conditions, which includes the pulmonary edema that is associated with congestive heart failure, or the pulmonary edema that is related to non-cardiogenic causes. It is used in the treatment of edema that is associated with cirrhosis, which is also called as ascites, which is the edema of the peritoneum, or there's accumulation of fluid in the peritoneum, which is known as ascites, and loop diuretics are the mainstay of therapy for the treatment of ascites. They're also used in the treatment of acute renal failure because they pushes the kidney, because they increases GFR, and this is how they challenge the kidney in any acute state and increases the urine output. They are used in the treatment of hyperkalemia, as the blockage of NKCC2 results in the excretion of more potassium from out of the body, and this is how they're used in the treatment of hyperkalemia. They're also used in the treatment of A9 overdose. So any condition in which there is a toxic ingestion of bromide or fluoride or iodide, which are reabsorbed in the thick ascending loop of Henle, those saline solutions, they must be administered to replace urinary losses of sodium and chloride, so as to avoid any extracellular fluid volume depletion. So this is how they're used in the treatment of A9 overdose. So the toxicity is obviously the direct extension of the therapeutic effect. So if they're used in the treatment of hyperkalemia and they reduces the concentration of potassium in the body, they can also cause hypokalemia. So hypokalemia, which is associated with metabolic alkalosis. They're very notorious in causes the ototoxicity. So loop diuretics, they causes dose related hearing loss that is usually reversible. If you stop the drug, the ototoxicity is reversible, and it is most common in patients who have diminished renal function or who are also receiving any other ototoxic agent, for example aminoglycoside antibiotics. They can cause hyperuricemia. So loop diuretics, they can cause hyperuricemia, and they can precipitate attacks of gout, and this is associated with hypovolemia because it causes the reduction of the volume in the or the fluid status of the body. The hypovolemia associated enhancement of uric acid reabsorption in the proximal tubule, and it may be prevented by using low doses to avoid the rapid development of hypovolemia. So as it decreases the concentration of potassium, it also decreases the concentration of magnesium. So hypomagnesemia is also common with the use of loop diuretics and hypomagnesemia itself is associated with the development of hypokalemia. There are also some allergic reactions reported with the use of loop diuretics. As I've already discussed, that these all loop diuretics, with the exception of ethylphenic acid, they are sulfonamides. So skin rash and eosinophilia and interstitial nephritis, they are occasional adverse effects of these drugs. So this toxicity is also reversible, and after you withdraw the drug, the toxicity is completely reversible. So So now there is a very important concept which I am going to explain to you guys, is that as we have already discussed that the NKCC2 along with the sodium, potassium, magnesium, sodium, potassium and chloride, magnesium and calcium is also lost. However, loop diuretics, they cause hypokalemia, they cause hypomagnesemia, but they cause hypercalcemia as well, which is a paradoxical effect as opposed to the mechanism of the action of the drug. Now, how this happens is that the patient who have the causes hypercalciuria, which usually lead to mild hypocalcemia. Initially, when you give the loop diuretic, it increases the excretion of calcium. So it can cause a very mild hypocalcemia in the in the starting phase. Now, what it will happen that there will be a secondary hyperparathyroidism, and that will result in the reabsorption of calcium in the other parts of the nephron. So it does not cause hypocalcemia, and it causes hypercalciuria instead. So this was all about the loop diuretics. The contraindications of these are any patient who exhibit any allergic reaction with any other sulfonamide, they may have an allergic reaction with the loop diuretics as well. And also in the overzealous use of any diuretic is dangerous in the patients with hepatic cirrhosis or borderline renal failure or heart failure. So we have to be careful about the fluid status of patient before giving them any diuretics, and especially loop diuretics, because they are very aggressive when it comes to diuresis. So now we have the other part, which is called as distal convoluted tubule, and only about 10% of the filtered sodium chloride is reabsorbed in the distal convoluted tubule. So we have a channel which is known as NCC, which is sodium and chloride channel, which works in the distal convoluted tubule. This channel, it causes reabsorption of sodium and calcium. So in normal kidneys, normally functioning kidneys, the sodium and chloride, they are being reabsorbed into the blood by the aid of this channel in the distal convoluted tubule. There is also reabsorption of calcium in the distal convoluted tubule by the effect of parathyroid hormone. This calcium goes inside and the sodium goes outside, and this is a whole another mechanism. So we need to remember that there is a channel which is known as NCC, which is called as sodium chloride channel, and this channel is responsible for the reabsorption of sodium and chloride back into the blood. And this mechanism, this happens in the distal convoluted tubule. So now we have drugs which act on these channels and which block this channel, and causes a resultant diuresis, because the loss of sodium and chloride is also associated with the loss of water. So the thiazide diuretics, a prototype of these diuretics is hydrochlorothiazide. So this hydrochlorothiazide is also sulfonamide derivative, and There are some other members of this family as well, which includes chlorothiazide, chlorothalidone, which also acts in the distal convoluted tubule, and we have indapamide. So these are the drugs which acts in the distal convoluted tubule. Among all these, the chlorothiazide, it is the longest, or the longer, it has a longer activity. As far as the pharmacokinetics or chemistry of thiazides is concerned, they all have a unsubstituted sulfonamide group, which means they are sulfonamide derivatives. They can be administered orally, all of them, and they're different. They have differences in their metabolism. Chlorothiazide is the parent of the group, and it is not very lipid soluble, and it must be given in very large doses, because it is a lipid soluble compound and it needs to be given in high doses for the required or for the desired effect. And it is also the only thiazide that is available for the parenteral or IV administration. Hydrochlorothiazide is considerably more potent, and it can be used in lower doses, so it is more potent. Chlorothalidone, it is slowly absorbed and it has a longer duration of action. However, indapamide is excreted primarily in the biliary system. Enough of the active drug is cleared by the kidney to exert its diuretic effect. So this was all a little bit about the pharmacokinetics of this drug. We have already discussed in the pharmacodynamics that it blocks the NCC channels, and when these drugs blocks the NCC channels, there is a excretion of sodium and chloride, and along with sodium and chloride, water is also excreted from out of the body. There is also enhanced calcium reabsorption. Moving towards the clinical indication of this drug, we are using thiazide diuretics in the treatment of hypertension, because they get rid of the excessive fluid in the body. They're used in the treatment of heart failure, nephrolithiasis, and nephrogenic diabetes insipidus. Nephrogenic DI or nephrogenic diabetes. The toxicity of these drugs is that they may cause hypokalemic metabolic alkalosis. They can cause, as with all diuretics, we have seen that there is reduced concentration of potassium, which can lead to hypokalemia. They can also impair the carbohydrate tolerance. Now, this is something new, that how these drugs are going to impair the carbohydrate tolerance. So hyperglycemia, it may occur in patients who are overtly diabetic or who have been even mildly abnormal glucose tolerance tests. The effect is due to impaired pancreatic release of insulin, and it diminishes the tissue utilization of glucose. So this drug, it directly affects the pancreas as well, that it impairs the release of insulin from the pancreas, and it also diminishes the utilization of glucose. So both these effects, they will cause an increased concentration of carbohydrates in the blood, resulting in hyperglycemia. So these drugs, they can also cause hyperlipidemia, which is also another important factor in the patients who already have diabetes or who have ischemic heart disease. So they can increase a total of 5 to 15% in the total serum cholesterol and LDL, and these levels, they may return towards normal after a prolonged use of this drug. The hyponatremia, because it blocks the NCC channel and increases the excretion of sodium. So hyponatremia is a very important adverse effect of thiazide diuretics, and it is caused by a combination of hypovolemia induced elevation of ADH and also reduction, which causes reduction in the diluting capacity of the kidney. So as with all other diuretics, there are allergic reactions seen with thiazide diuretics as well, and they share cross reactivity with other diuretics, with other, sorry, sulfonamides. So in other toxicities, patients may suffer from weakness or paresthesias or fatigue, and there have been some cases of impotence that are also reported with the use of thiazide diuretics. So we have to remember, we have to keep all these side effects in the back of our heads when we are prescribing thiazide diuretics to any patient. So moving on, we have osmotic diuretics. These are the drugs that act on the proximal tubule and the descending loop of Henle. These osmotic diuretics, they have a very simple mechanism of action. But as we know that there is a simple concept of diffusion, then if on the side of left side of membrane we have more solute and we have more water here, the water will go into this side in order to achieve equilibrium. So this is a simple mechanism, and this mechanism is basically used by these osmotic diuretics, that they will create a, because these they are osmotically active, so they will create a more solute concentration into the lumen side. And this solute concentration, because these are mannitol or these diuretics, they are present in the lumen of the urine and they are not reabsorbed, so they will create a pressure, they will create an osmotic pressure which will pull water out from the tubules into the lumen, and this is how the water is excreted into the urine. So the mechanism is pretty simple, and it encompasses, or it uses the phenomena of simple diffusion or simple osmosis, which is driven by an increased amount of solute into the lumen. So these are, as far as the pharmacokinetics of these drugs are involved, these are they're absorbed rapidly. They are very poorly absorbed by the GIT, and they're absorbed rapidly by the IV administration. So if you give the osmotic diuretic, and the example of this is mannitol, if you give mannitol by oral administration, it will not be absorbed into the bloodstream and it will cause only diarrhea. So in the if you give it in the IV form, it will cause the water diuresis. It is not metabolized and it is excreted within 30 to 60 minutes of the administration. So the onset is very quick and the duration of action is around 30 to 60 minutes. We'll have to repeat the dose of mannitol if we want to achieve a more prolonged effect. So the pharmacodynamics, we have discussed the pharmacokinetics, and moving on towards the pharmacodynamics, the mechanism of action is in the proximal tubule, and also descending loop of Henle. So it opposes the action of ADH in the collecting tubule. ADH is basically an antidiuretic hormone, and the excessive water loss is the result of this drug administration. Now, moving on towards the clinical indication of these drugs, they increases the urine volume. So they are indicated in the treatment of their use and the large pigment loads also. So they are used in the conditions in which there is an increased pressure of the fluid in various segments and of the body. And the most common example is they are used in the setting of increased intracranial pressure. So when there is an increased intracranial pressure and we prescribe mannitol, it is given in the dose of 1 to 2 gram per kg per dose, and the dose is repeated and the dose can be repeated every 6 to 8 hourly, and it decreases the intracranial pressure in 60 to 90 minutes. This is a very good drug that is used in these kind of emergent situations. The toxicity is extracellular volume expansion, because it actually pulls fluid out of from inside the cell into the extracellular compartment. So there is an expansion of the extracellular volume, because there are great losses of water from the body, so dehydration can occur, and this dehydration can affect the kidneys as well. Hyperkalemia and hypernatremia is seen with the use of mannitol, because it causes the excretion of water and not potassium and sodium, not the ions. So hypernatremia and hyperkalemia is often seen with the use of mannitol. So this was all about the toxicity of the mannitol. Moving on, we have the last segment, which is the cortical collecting tubule. In the cortical collecting tubule, we have aldosterone. The main